Thank you so much for joining me. I hope you're hearing me okay, both in the room and online. We're really excited tonight for having you here because we have a really exciting program. We have great speakers, Dr. Robert and Dr. Tarhini, which I'll introduce a little bit later. But really what I think, most excited about is the fact that we have some new data and new information that will really help us decide how we're going to be sequencing the treatments for our patients with BRAF-mutated melanoma. And I have to say that, this situation, I would say in general in melanoma, we're somewhat lucky that in the last, decade or so, we've had so many approvals. And that's really very important for our patients. We have more agents to be able to treat them, give them better outcomes. But it also actually creates a lot of conundra, almost similar to, if you've ever walked into a Starbucks and were asked all of the questions about which flavors would you like? And I think that's kind of a situation where we deal with our patients now, that it's great we have many options, but how do we decide which option to choose and how do we sequence those combinations? So my name is Hussein Taubi. I'm Deputy Chair and Professor in the Department of Melanoma Medical Oncology at MD Anderson Cancer Center, and I'm, again, excited to be sharing some of this with you. So I'm going to just start by setting the stage, just giving you a sense of what are the issues that we deal with. And as you know, we have our patients with metastatic melanoma have BRAF mutations about 50% of the time. The range goes from 40 to 60%, but say half the time those patients will have BRAF mutations. And once you have a BRAF mutation, again, you're in a very good place because you have the choice of using not just immunotherapy, but also potentially targeted therapy with either with several combinations available of BRAF and MEK targeted therapy. Now, the interesting thing I'll tell you, as academic oncologists, and we've been, doing this over the last decade, we've, generally tried to start immunotherapy up front for our patients, but the debate has raged for a long time about which choice should you do, the targeted therapy or the immunotherapy? And we didn't really have any way of telling. All of the trials that have led to approvals have been done in first-line disease in patients that were treatment naive and had shown improved survival, improved outcomes for those patients. So there was not really good direct comparisons. So what you're looking at here is a kind of a market level research looking at how common is for the different treatments to be given in a community setting, and you see the number of 162 patients. So blue and below is immunotherapy, and then you see here even single agent vemurafenib, single agent dabrafenib, remarkably are still used, and you'll hear some of the data now how combination is really the way to go with targeted therapy anyway. But what you see in these curves is that almost 60% of patients are starting first line with BRAF targeted therapy. So keep that in mind as we go through our program today, because that's, moving forward may not be the recommendation as you'll go through the data with Dr. Robert and Dr. Tarhini. And so as you think about these two approaches, targeted therapy or immunotherapy, we're just going to go briefly through this, where you see that what we see with something like Ipi/Nivo, for instance, and is you see this early progression with the blue curve. We lose a lot of patients in the first year that progress on treatment, but then we have about 50%, 55% of patients that respond and do remarkably well. And now we have 6.5-year data. In fact, on Monday, you're going to have 7.5-year data from that combination that shows us that those patients are almost cured. BRAF and MEK combinations, we know, give a lot less progression up front. You get a lot of responses. Almost 90% of patients will have some form of a response. But we also know that over time that the progression happens, median about a year to 15 months. We know that about 20% of patients do well long-term. But again, this is a lot lower than Ipi/Nivo, or at least immunotherapy. So the question here is, it may look simple that everybody wants to get cured, and we want to try to get for the largest proportion of patients that have, that have that long-term or tail at the end of the curve. But the clinical reality is a lot more different than these, the curves show you. Sometimes you actually need that early response. You absolutely want to give your patient a quick, you take your pills and within 48 hours you're going to start to feel less pain and less symptomatic or even from your brain disease. So it's not as simple as choosing what gives us the best long-term survival. The clinical realities are actually challenging. So what we're going to be doing today is Dr. Tarhini is going to walk us through every piece of data that's out there right now to show us, the response rates and the PFS and the long-term outcomes from both immunotherapy and targeted therapy combinations. And then Dr. Robert will go through a case-based discussion of if you have a patient with this kind of presentation with a BRAF mutation, how do you manage those patients? And along the way, you're welcome to ask questions. This is an interactive program, so we'd be interested in either cases that you have to discuss or kind of nuances that you'd like to bring up. So with that, I'm going to move forward to, again, this is our agenda. It's going to be the lecture and then the case-based discussion. And I'll start by introducing my good friend and colleague, Dr. Tarhini, who is formerly from the University of Pittsburgh, where we trained together, but he is now a leader in cutaneous oncology at the Moffitt Cancer Center. He is professor and a senior member of cutaneous oncology. He's also the chair of the Orion Scientific Committee and Immuno-Oncology Research Subcommittee. Dr. Tarhini, great to have you here. The floor is yours.
Thank you. Thank you, Hussein. Excited to join you and Caroline in this in-depth discussion of the latest data in managing BRAF-mutated melanoma. So, as Hussein mentioned, I will provide an overview of the efficacy data and toxicity data from the pivotal trials that led to the approval of the main agents or main regimens that we use in clinic today. So I'll be discussing Checkmate 067 that tested the combination of PD-1 CTLA-4 blockade, ipilimumab, nivolumab, and nivolumab versus ipilimumab. We will also discuss briefly Keynote 006 that tested pembrolizumab. We will go over the data, long-term survival data primarily from the BRAF-MEK inhibitors, vemurafenib, cobimatinib, dabrafenib, tramatinib, and encorafenib, binimatinib. We will review IMspire 150, vemcobi atezolizumab, the triplet combination that is also approved for our patients with BRAF-mutated melanoma. And then the most recent data from Relativity 047, LAG-3 inhibition with PD-1 blockade, fixed-dose combination of relatlimab and nivolumab. Following this, we will move on to discuss the evidence-based results from the sequencing studies, the Sequential and DreamSeq clinical trials. So in terms of the national guidelines, these agents are all listed as options in the first-line and second-line therapy for patients with BRAF wild type and those with BRAF-mutated melanoma as shown here. Key thing to look at is the long-term survival benefits from these agents. Overall, what we see is that when we do cross-trial comparisons, although it's not necessarily a statistically let's say, valid thing to do, but we see that there is a trend towards an improved overall survival in favor of starting immunotherapy in the front line. So data from Checkmate 067 showed 5-year survival rates of 52% with Ipi/Nivo and 44% with nivolumab, as compared to the data with dabrafenib tramatinib from the COMBI-D and COMBI-V studies of 34% overall survival at 5 years. So focusing on the, these agents, let's say one by one, starting with PD-1 blockade as monotherapy. We know that we have pembrolizumab and nivolumab in the clinic. Data from Keynote 006 supported an overall survival rate of about 42%, median PFS of 8.4 months, and median overall survival of 32.7 months as compared to ipilimumab in that study. Interesting to see also the 5-year survival rates and 7-year survival rates of 43% and almost 38% overall. What was important about Keynote 006 is that it also allowed us to look at the possibility of discontinuing treatment in patients who do not progress following the initiation of anti-PD-1 immunotherapy. This study discontinued treatment at 2 years in patients who did not progress, and a sub-analysis from 103 patients who had at least a stable disease showed an overall survival rate at 5 years that is about 93%, with 5-year PFS of 70%. Patients who eventually progressed were able to be salvaged with reinduction, and of course have the opportunity to be salvaged, let's say with BRAF-MEK inhibitors if they had BRAF mutation and so on, again supporting the possibility of stopping treatment rather than an endless treatment following initiation. Moving on to the combination of anti-CTLA-4 anti-PD-1, Checkmate 067. This is the 6.5-year PFS and OS data that was presented by Jack Wolchok last year at ASCO in 2021. What we've seen from this data is that there are durable 5-year PFS and OS rates with 5-year OS rates of close to 50%. And when they did the, let's say, melanoma-specific survival, was upward of 50%, about 58% overall. In zooming in on the BRAF mutation, let's say, patient population, we see that the results are comparable between patients who had BRAF mutant and BRAF wild type in terms of the long-term benefits. When we look both at the ipi-nivo combination and at nivolumab. Here, let's say the overall survival rates were almost similar between BRAF mutant, BRAF wild type, slightly lower for BRAF mutant in terms of progression-free survival. But in terms of overall survival, there appears to be an advantage for the BRAF mutant patient population at 5 years in terms of overall survival. And those who were treated with ipi and nivo, those who were treated with nivolumab, there are similar benefits. Again, highlighting the importance of the BRAF-MEK inhibitors as a salvage in patients who progress following initiation of immunotherapy. This study also highlighted the importance of, or the prognostic value of the liver metastases and visceral metastases, probably reflecting the tumor burden overall, and showing here that the patients who had liver metastases unfortunately have a disadvantage overall and less survival compared to those who are without liver metastases. The challenge with CTLA-4 blockade as monotherapy and in combination is obviously the higher rate of immune-related adverse events. So what Checkmate 067 reported is a 59% rate of grade 3/4 immune-related adverse events compared to 24% with nivolumab. And those that are probably most clinically relevant, so treatment-related AEs leading to discontinuation of any grade, were 42% with ipi-nivo compared to 14% with nivolumab as monotherapy. The exciting data was presented recently, obviously, and published in the New England Journal of Medicine, is now the introduction of LAG-3 inhibition. So the fixed-dose combination of relatlimab, nivolumab, compared to nivolumab in the Relativity 047 study. The primary endpoint in this study was the progression-free survival, and this study obviously met its primary endpoint. Was positive, hazard ratio of 0.75, and median of 10 months compared to about 4.6 months. Obviously leading to FDA approval, and this is an option now that we have in the clinic. Now, Hussein will update this data on Sunday during the oral presentation melanoma session. The overall survival and response data were also noted at a median follow-up of 19 months, presentation by Georgina Long in the ASCO plenary series. There was an interesting, strong trend in favor of improved overall survival of hazard ratio of 0.8, was not statistically significant, but there was a strong trend or clear trend there. Also, when looking at the 1-year and 2-year overall survival rates in between the combination and monotherapy. The response rates were 43% and about 33% respectively, also in favor of the combination. What's also important here is obviously focusing on the BRAF mutation patient population, and these appear to derive similar benefits to those with wild type. So we see it again in terms of combination immunotherapy, whether it is with CTLA-4 blockade and PD-1 blockade, or LAG-3 inhibition and PD-1 inhibition, that patients with BRAF-mutated melanoma who start these combinations in the front line appear to derive at least similar benefits compared to the wild-type patient population. One important, addition from the LAG-3 combination here is the safety profile when considering the CTLA-4 blockade, the Ipi-Nivo combination. We see that the rate of a grade 3/4 immune-related adverse events was about 19% with Rela-Nivo here, and those leading to discontinuation of any grade about 15%. Clearly, let's say, a major advantage in terms of combination immunotherapy in the clinic. The data with targeted therapy, I think it's important to note that there are long-term survival outcomes, and we have seen these in the 5-year updates with the BRAF-Mutated, Vemcobi, and Ankubini. Overall, what we see in terms of overall survival benefits is that the 5-year survival rates range somewhere between 30 to 35% in patients who started BRAF-MEK inhibition in the first line. Similar, let's say, durable benefit in terms of progression-free survival, that where we noticed that about 15 to 20% of patients continue to be progression-free at 5 years. Most importantly, those benefits are seen in patients who have significant responses, like complete responses, for example, as seen in the analysis with the BRAF-Mutated and with Vemcobi. Somewhere between 50 to 70% of these patients were alive at 5 years, those who achieved a complete response. Another thing is that patients who have a low LDH also tend to have durable long-term benefits in terms of overall survival that was observed in these studies. The important addition also in 2020 was the triplet combination here with anti-PD-L1 inhibition at atezolizumab with Vemcobi in the IMspire 150 study. This study was positive in terms of the primary endpoint. The hazard ratio was 0.78, and the median progression-free survival was about 15 months compared to about 10.6 months, leading to approval and addition to the clinic. Interestingly, in parallel, the COMBI study, although it showed a trend in terms of improved PFS in favor of the triplet combination, was not statistically significant and failed to achieve regulatory approval. An interesting abstract that will be presented by Dr. Doomer on Sunday, also during the same oral melanoma presentation session, is the activity of the triplet combination here, atezo-Vemcobi, in patients with brain metastases, including patients who are symptomatic and on corticosteroids. These constituted about 37% of the patient population, and the overall response rate as assessed by investigators, about 50%. The median duration of response appeared to be let's say modest, but we'll see. I mean, we'll look forward to this data by Dr. Doomer on Sunday. But this could be an option for patients who cannot receive, let's say, Ipi-Nivo in the first line due to high doses of corticosteroids, where the response rate based on the Checkmate 204 was around 20% or so. So what is the recent evidence-based sequencing data in BRAF mutant melanoma? The Sequential study was a study that randomized 3 cohorts of patients into, and those patients had BRAF-mutated melanoma, into first-line BRAF-MEK inhibition, Ankubini, and at the time of progression received the combination of ipilimumab and nivolumab. The second arm, arm B, patients started with Ipi-Nivo in the first line, and at progression transitioned to Ankubini as a combination. And the third arm was the so-called sandwich arm, where patients received Ankubini for 8 weeks and then moved on, in the absence of progression, to Ankubini. The data were interesting. Overall, there were no statistically significant differences between the three arms, and probably is related to the relatively small sample size in each of these. But there was an interesting trend that was seen both in the Ipi-Nivo first-line arm and in the sandwich arm, where we see that numerically the overall survival at 3 years here, around 60%, was numerically better than arm A, which started with Ancobini and then at progression transitioned to immunotherapy. The similar trend was seen also in terms of progression-free survival. Again, about 53-54% PFS rate at 3 years in those who had IO or sandwich arm, compared to about 41% in those who started with Ancobini and transitioned at progression only to IO. So in a way, it supports IO in the first line. The other study is the DREAMseq study. This is an ECOG-ACRIN study, EA6134, where Mike Atkins designed and started this study in 2015. The study was designed to randomize patients with BRAF-mutant melanoma into Arm A, which is induction Ipi-Nivo, and at progression, patients would be transitioned to the BRAF and trametinib. Arm B, the BRAF and trametinib, and at progression transitioned to Ipi-Nivo. This study had a primary endpoint of 2-year landmark overall survival. It met its primary endpoint, so the 2-year overall survival rates were 72% compared to 52% in favor of immunotherapy upfronts. In other words, 20% reduction in the risk of death at 2 years. So in conclusion, 5-year overall survival rates are more than 40% with single-agent anti-PD-1 and more than 50% with anti-PD-1, anti-CTLA-4 combination immunotherapy. The option of single agent or combination may be tailored based on patient needs. Fixed dose LAG-3 PD-1 blockade has emerged as a new first-line option with relatlimab and nivolumab. Target therapy is highly effective for BRAF-mutant melanoma. There are 3 approved regimens, and 5-year BRAF inhibitor and MEK inhibitor data show durable benefits in a subset of patients. There is a limited role for BRAF-MEK anti-PD-L1 data with Vemcobi-Atezo that has emerged, and this has a role in the clinic. And the recent data from DREAMseq supports IO combination as first-line therapy in BRAF-mutated melanoma, although it's important to keep in mind that there continues to be a subset of patients that would still need to have BRAF-MEK inhibition in the first line. If they have rapidly progressive disease where we need an urgent response, these are the patients that would still continue with BRAF-MEK inhibition in the first line. And important to keep in mind that patients who seem to progress quickly on IO therapy, there will be an important need to salvage them as soon as possible with BRAF-MEK inhibition.
We have some questions online. One of them I will like you to address now, Dr. Tarhini, and then we'll leave the rest towards the end, but I think it's very relevant. One of the questions talks about AEs. Are there fewer AEs when sequencing treatment from targeted to immune checkpoint than vice versa? Any information from the DREAMseq data in terms of the toxicity?
So I think the likelihood of having toxicity is probably the same. So with Ipi-Nivo, whether you give it in sequencing or you give it upfront, it's still the same rate of grade 3-4 adverse events, let's say.
Thank you. That was great. Okay, great. Well, we'll move on to Dr. Robert again. I'm really pleased and honored to present Dr. Robert, who's the head of the dermatology unit and the director of melanoma research team at the INSERM, and Gustave Roussy and Paris-Saclay University from Villejuif, France. And Caroline will walk us through a few cases. And, again, there are some questions online, but I think some of the cases will illustrate some of those same issues, and then we can do another Q&A at the end as well. Go ahead, Dr. Robert.
Thank you. Thank you very much. I'm very happy to be here and to discuss with you this case. And it's really, I think it's really important that you know that it's really an everyday question. This is something that happens every day in our clinic and probably in yours too. So let's imagine a woman of 62, year old, and she has stage 4 metastatic melanoma, unresectable, with several lung metastases. She has high LDH, above the upper limit of the normal, but not above twice the upper limit, between 1 and 2. And she's not in a perfect performance status, but she can still do some easy work at home, PS1. And she's awaiting for the result of a baseline testing. So what are we waiting for? I think we would like to make sure that she does not have any brain metastasis. So we have to make sure that she had an imaging of the brain. And also we need to know her BRAF mutation status. So you might think, why? Because you just told us that regardless of the BRAF mutation status, we would like to initiate the treatment with immunotherapy. Yes, okay, but at the same time, it's very good to know, to anticipate things and to exactly know. You don't exactly know what you are going to prescribe to your patients until you have discussed with your tumor board and with the patient. And it's very important to know what you have in front of you in this specific situation. So we always like to have the BRAF mutation status. Plus, in a lot of centers, there are some clinical trials, like, for example, the Sequential trial. Right now, we have the EORTC trial that is almost finished in terms of recruitment, but it's a sort of variation of the sandwich trial. So we need to know the BRAF mutation status at the beginning. And the patient, they read on the internet, and it's important that we know exactly what we are going to fight against. And as we heard from Ahmad, we have several possibilities that are approved for treatment of this patient in first-line treatment. We can give either a monotherapy with anti-PD-1, pembrolizumab or nivolumab. We can give a combination, nivolumab, ipilimumab. We can give nivolumab, relatlimab, more recently authorized in the US. It's not yet in Europe, actually. And if the patient is BRAF mutant, we know that we have other options, combination of targeted agents, the 3 combinations. Okay. So now we are going to discuss, and we need to have the confirmation of the BRAF mutation status, yes or no. Well, in this case, she has a melanoma with a BRAF mutation. Just a small parenthesis, sometimes you want to have the information quite quickly, and you can also have immunohistochemistry staining. You have an antibody that recognizes very specifically the BRAF mutation, but it's only recognizing V600E. So if it's positive, it's very good. Usually it's confirmed by molecular biology, but in fact, I think it's very good if you have the staining. But if it's negative, you have to check if it is not V600K, which is also sensitive to BRAF and BRAF-MEK. So it's you need to do the PCR. Okay, so Margaret, this patient, she has a BRAF mutant melanoma. So we have these options. So I think maybe we could discuss. So you say? What would you think?
So I think it's you present a really interesting case. Remember, the high LDH is probably, of all of the 3 things that you noted, are probably the one thing that kind of we take note of, because generally when we think about BRAF-MEK, I even mentioned it when I was starting, is that if you have someone with rapidly progressive disease or aggressive disease, you think those are the patients you need to jump on and treat with targeted therapy. The interesting part is we also know that patients with high LDH actually do pretty much less well than patients that have normal LDH with targeted therapy as well. So having a high LDH is something that drives me a little bit away from BRAF-MEK, even regardless of the randomized data that we just heard about. Dr. Tarhini, what are your thoughts?
I agree. I think LDH by itself, in patients who we have time to treat, I would favor immunotherapy in the first line. But what I would watch is a patient who walks into the clinic or cannot walk to the clinic, comes in a wheelchair, or somebody that we see in the hospital. These are the ones where I would consider BRAF-MEK.
Exactly. She's not symptomatic. She's just a little bit tired. She has not something that threatens her immediately. But the prognosis is not so good because of the high LDH. So, yeah. I just would like to make another small parenthesis. This is a translational work that we did in our lab. We work on the persister cells. These cells that hide in the body, we don't see them with the CT scan, we don't see them with our examination. But unfortunately, after some time, we know that they have been there because we see a relapse. And sometimes it can last for a long period of time, this sort of period where you have these persister cells invisible. We call them the invisible threat. And in the lab, you can recapitulate that. If you take some melanoma cells, you put them in culture with BRAF-MEK inhibitors. Almost all of them die in 2 days, but not all of them. This is very important. You have about 10% of the cells that remain in your petri dish. They don't look so in very good shape, but they are there. They are not dead. If you take them off drug, if you take off the drug, you take the medium off, and then you re-challenge them after 1 day, 2 days, 3 days, 5 days, progressively they go back to the same sensitivity as they were before, what we call the parental cell. So it's not that they have acquired a mutation of resistance. It's something that is very plastic. They have, so it's a lot of epigenetic mechanism. I mean, there are a lot of data about this plasticity of the persistent cells, but we also showed that they modulate their translation, for example, of the RNA. But then what I want to insist on is that if you leave these persister cells under the pressure of the BRAF-MEK inhibition, after some months, you have clones that have acquired resistance mutations. And when we did that in several clones, we found the same mutation that sometimes are found in the patients. So this demonstrates in the melanoma model that persister cells feed resistance. They are a reservoir for resistance. So I'm not saying that this happens only with BRAF-MEK inhibitions, because we know that we also have relapses with immunotherapy. But this is something that in vitro really demonstrates the fact that you can create this persister that can lead to resistance. Okay. So we are not going to decide how to treat our patient based on petri dish, of course, but we need to understand. What we need is what Ahmad showed us, this kind of data, who tell us that statistically it's better to initiate the treatment with ipilimumab, nivolumab than to begin with BRAF-MEK. So it is the reason why I think all of them would prefer initiate the treatment in this patient with immunotherapy.
So Caroline,
yes.
Can you go back to the DreamSeq for a second? I really want us to discuss DreamSeq for a few more minutes. I mean, I think I had the same discussion with Mike Atkins. I was telling him the best thing about this study is it's not a little positive. It is very positive. I mean, 20% survival difference at 2 years. And I think that is a major, major difference. And I think before he started the study, we all felt as academic oncologists, we all, favored immunotherapy. We knew we wanted to get the long-term outcome for our patients. I remind everybody that this study was actually, again, combination ipi-nivo versus dabrafenib trametinib. The option of single-agent PD-1 is not part of this, right? But we always felt like we should do it. We couldn't make that decision without randomized phase 3 data. And what was impressive is, again, it wasn't a little positive. It was a 20% overall survival difference. So just interested in both of your thoughts about the fact that, again, this is still not, single agent. And I'm getting some questions online as well about, well, what about Nivo-Rela? I mean, this is a very, we have to take that study in the context of exactly how it was performed. It was ipi-nivo versus dabrafenib trametinib. So what are your thoughts on that?
There is just a little bemol for me that the combination of targeted therapy did not perform well in this trial, because we know that we can obtain close to 70% of response, and here it was much lower. I don't really know why. So that's a little bit annoying. I don't. It does not jeopardize the results in terms of. We know from other trials also. I mean, it's very consistent with what we know, as you say. But it is true that we have not such a good response with targeted therapy here.
Yeah, no, I agree with you.
43%.
Right, yeah.
Much lower than what we should get.
I think, overall, the fact that this study was conducted within the cooperative groups, there are limitations. It's, conducted in hundreds of sites across community sites, in the country. So that's one limitation, that we see less activity, kind of worse results overall in cooperative groups compared to industry-sponsored studies. The other thing is the patient population that entered the study were patients who were not necessarily eligible for monotherapy. They were patients that would usually give Ipi/Nivo and end up on this study. You see the LDH was 40% of the patients had high LDH, 60% had M1 CDCs, or what we consider today M1C, M1 DDCs. So it was a high kind of risk patient population overall.
But as a clinical experiment, it was well conducted, and so the internal validity of it is absolutely appropriate. Correct. Thank you.
What about the sandwich as compared to initiation with Ipi/Nivo? So it's true that it's difficult to conclude because we don't have a lot of patients statistically, and also maybe we might have some more elements later on. But what we see here again is that the arm A, which begins with BRAF-MEK and changes at progression, does not perform that well in comparison to the B, which is Ipi/Nivo and then BRAF-MEK at progression, or the so-called sandwich, which is BRAF-MEK inhibition for 2 months, followed by Ipi/Nivo quite rapidly, only 2 months of. So the 2 last arms do as well, and they seem to do better than initiation with BRAF-MEK. So again, the same signal that maybe it's better to have an immunotherapy quite early on. So now we have the BRAF mutation that is confirmed, and we have this recommendation if you just look at the authorization. And for this patient, I think we would initiate with immunotherapy, and then we would discuss with the patients about, does she accept to take the risk of the combination of nivolumab plus ipilimumab? I think we need to put that in these terms. We have a combination that gives higher results, but much higher toxicity. That's what I tell my patients. We have better results. It seems that we really have consistently better results, although that we know that for the 67, it was not really powered to show the difference, but it's always on top, a little bit on top, above nivolumab monotherapy, but much, much higher toxicity, and that needs to be really explained to the patients. We need to take our time, and also I think we have to really make the effort to say that there might be very severe adverse events. We have to tell that the very severe one, they are very rare, but although there are some adverse events that are not so rare, like loss of the thyroid function, between 10 and 15% of the cases. It's not considered very severe, but it's annoying to take hormones, every day of your life. So of course, when you are in a situation of a metastatic disease, the balance is really in favor of the treatment. But okay, so we have to really take our time to talk with the patients and the family. And also, I think what is very important to tell them, I'm sure you will agree, is that to tell them that whatever that their choice will be there. And if they accept the proposal to have a combination of immunotherapy, they have really to know that we are always there to help if there is something, and we have to make sure that they can reach us, the team, anytime, to make sure that they understand how to reach us. So there are big differences between the toxicity of immunotherapy. So this is one of the first publications that was detailing the adverse events that we could see on our patients treated with the combination. So you see it's quite rare when you have adverse events grade 3 and above that are more frequent than the grade 1 and 2, and this is the case. We have more grade 3 and 4 adverse events than grade 1 and 2. Overall, we have close to 60% of patients with grade 3 and 4 adverse events, so it's really heavy in the balance. And so I insist again, you see thyroid dysfunction. It's classified in the grade 1 and 2, but I mean, it needs to be said to the patients clearly. And we don't see here the very severe ones, the ones we are very afraid of, like encephalitis, myocarditis, because it's very rare. But I think it's important to say that it can happen. So we know how to manage with adverse events. We have algorithm. We know that for grade 1 and 2, usually we can continue the treatment, and we have to give symptomatic treatment. Grade 2, we begin to pay attention. If it continues, we will stop the treatment, and we will give, of course, symptomatic treatment and be ready to prescribe steroid that we will prescribe anyway for grade 3 and above, and sometimes intravenously. And sometimes we will give more potent immunosuppressive drug. So this is also something that is reassuring for the patient to tell them that we are quite used to manage these adverse events. And of course, with BRAF-MEK agents, inhibiting agents, we have a very different toxicity. We have some class effects which are shared among the 3 combinations, but we also have some adverse events that arrive more frequently with one of the combinations. For example, more frequently fever, chills with vemurafenib, with dabrafenib, trametinib. More frequent photosensitivity, very frequent photosensitivity, very annoying. I think it's one of the main reasons why we prescribe very rarely this combination. And I think, I'm not sure if you agree. We'll see. Maybe we have to see. But I think gastrointestinal adverse events are more frequent with encorafenib, binimetinib. Sometimes very severe colitis even. So we have also to pay attention and to know how to manage. But we don't have the permanent adverse events, and it makes a huge difference. Especially, this is not the case here, but when we discuss about treating patients in the adjuvant setting. Here we don't have the endocrine adverse events, the ones that are permanent. So Margaret receives Nivo ipilimumab combination, and she unfortunately presents with a severe colitis that she presents after the second infusion, as it is quite often the case. And she has to be treated with high-dose steroid. She responds. And then we stop Ipi-Nivo. And I would like to insist on the fact that before considering a re-challenge with the same drug or continuing, for example, even with Nivo monotherapy, if we are afraid to give the third and the fourth course, we have to re-evaluate her because maybe we will have a good surprise and we will see that she responds to the treatment. And in this case, no need to re-challenge. So now let's imagine she had normal LDH and she's in perfect performance status. Would you have done differently?
Yeah, I mean, that kind of, again, first of all, even if I consider targeted therapy, this is a population with lung metastases and, basically limited, it seems, to lung metastases with LDH and PS4. The PS of 0 patients will do really well with that. I kind of disagree with some of the options because, as I will show on Sunday, there will probably not be a single situation where single agent PD-1 is going to be the answer. It's probably going to be PD-1 like 3. But honestly, this is a situation where you could think about single agent before we had Nivo-Lag in hand, and now Nivo-Lag, with only having M1A disease, normal LDH PS0, the response rates are exceptionally high, both with single agent nivolumab or with nivolumab relatlimab, and those patients do really well. So that is a very high consideration for me when I see a patient with that kind of presentation. Ahmed?
Yeah, no, I mean, I agree. You have a randomized phase 3 study which demonstrates the, kind of superiority of LAG-3 PD-1. Although I would still consider PD-1 in patients, let's say, if they have lung metastases but low tumor burden, or maybe older, I'd like to kind of minimize the risk of toxicities. Although with LAG-3, the toxicity profile is obviously favorable. But I'm still, going to look for those patients where I can do PD-1 as monotherapy.
You have from now until Sunday morning to maintain.
Exactly.
Yes, okay, just to remind us, you already showed that Nivo-Lag, regardless of the BRAF mutation status, it seems to be better than nivolumab. Okay, so now she has brain metastases. So they are not symptomatic, but then we could consider these different combinations. We have the triplet. The triplet is BRAF-MEK blockade plus an anti-PD-1. And here I would like, we are very lucky because we have a very, very expert in the field who published his paper. I would like, Hussein, that you comment this slide.
Yeah, thank you. So what Dr. Robert is showing is the 3-year data from Checkmate 204. And so, again, we know that single-agent PD-1 has activity intracranially as well. We know that the response rate from one single-arm study that was conducted at Yale was the intracranial response with pembrolizumab was about 20%. And then the ABC trial that was conducted in Australia randomized patients to Ipi-Nivo versus single-agent Nivo. And again, single-agent Nivo had a response rate of about 20%. So Checkmate 204 was a study in which we used ipilimumab and nivolumab. And just to be clear, it's ipilimumab 3 milligrams per kilogram, Nivo 1 milligram per kilogram, given for 4 doses. So the standard dose, as we call it in melanoma, as opposed to the flip dose, which uses a lower dose of Ipi. And we had an intracranial response rate of about 55% and a clinical benefit rate of 58%. So you see the waterfall plot there. So there's a lot of responses. I would say the median time to response was 6 weeks, so it was a very quick response. I can do the next and show, I think most importantly, the fact is it was very durable responses. So at 3 years, when we reported this back in November, we hadn't reached the median PFS. So we still had a 3-year PFS of 52%, so it was above the median still, if the patient was asymptomatic. And 87% of the responses were ongoing. And again, one of the things we have in a supplemental, by the way, we did a landmark analysis at 12 weeks. So if you had an intracranial response at 12 weeks, the overall survival at 3 years was 92%. So again, confirming that this combination is very effective in the brain. I'm sorry, did you have a question?
No, in other words, you tell us that you have a response that is as good as anywhere else.
Exactly.
If you are asymptomatic.
If you're asymptomatic. And the PFS that you see below is from patients that were symptomatic or receiving steroids at the time of initiation of therapy. The response rate was not good. It was 18% that we managed to actually have a response. And so it's a very low response. But what you see from this PFS curve is actually still flat lines. So actually the 4 responses that occurred were all durable. So every time you got an intracranial response, it was durable, but it was a much lower response.
So with BRAF-MEK, we know we have a previous publication with dabrafenib and trametinib. The response rate was not bad in the first cohort, which is really the only one that we can analyze because it's 78 patients. The other ones are really small. There were other kind of mutation of V600 and also some patients were symptomatic or pre-treated. But the cohort A, asymptomatic, no prior radiotherapy, you see response rates, it's good. It's more than 50%, 58%, so it's less than other sites, which is about 70%, but still, it's as good as your response rate with Nivo-Ipi, but in terms of duration of response, we are much less good. We are about 6 months of PFS median, so not durable responses. So the concluding thoughts are, I think we can say that the combination of nivolumab plus ipilimumab, I think should be considered a priority even if in patients with BRAF mutant melanoma. But we also can discuss nivolumab plus relatlimab or anti-PD-1 monotherapy in some cases, and also if the patient does not want a regimen that is very toxic. That is very important to listen to them. We have, of course, to remain very vigilant when we prescribe these treatments, even PD-1 mono blockade. I mean, we can have adverse events, so always remain very vigilant. And also, I would like to re-insist on the evaluation of the patients before resuming treatment. Sometimes you don't need.
We still have a few questions online that I would like to go through, but I think we've answered some of them as we discuss these cases, so I'll pick a couple of them. And again, if there are any questions directly from the room, I'll give the advantage to people that showed up in person. If anyone wants to raise their hand and ask us a question, I think this is a perfect time to do so.
There is something that is not a question, but that is very important, and I think we didn't say that, is that the big advantage of immunotherapy is that we can stop for patients who respond well, and we cannot stop even for very good responders with BRAF-MEK inhibition. We don't dare to stop because we are so afraid of the relapse. So I think it's a good point.
Absolutely. So I want to pick out the one about any role for PD-L1 expression, even to decide between dual IO or single agent. Dr. Tarhini, any thoughts on that?
I think, with PD-L1 expression, although it suggests a higher likelihood of benefit from immunotherapy, it does not exclude the likelihood of response. And we would still treat these patients, let's say, with combination immunotherapy, let's Ipi/Nivo, for example. So I would say at least no role in my clinic.
Dr. Robert, do you order PD-L1 for your patients?
I don't do it routinely. I do it for research. And why? Because it's not such a good marker. It's not very homogeneous. And we did this experiment we do the proximity between PD-1 and PD-L1. It's not something standardized, but we find that it's well correlated to response, better than PD-L1, but it's not something that we can use yet. But right now, I'm very happy that we are not restricted in our prescription and that we can prescribe anti-PD-1 or the combination to patients even with PD-L1 negative, because sometimes it works well. And it's not like we had a lot of things better that we could offer to our patients.
Exactly. I mean, it's kind of, obviously for practicing oncologists, you're used to ordering that for your lung cancer, colon cancer patients before you make any move. You have to get the result before you make the decision. For melanoma, we never actually order it, and when my patients show up with a PD-L1, most of the time I kind of shrug my shoulders and do what makes more sense based on the other clinical characteristics of the patients. I do want to address one questions about So recently we published, along with Georgina Long's group, collected data from patients that had received Nivo-Rela and then went to Ipi/Nivo afterwards, and it was a very small sample size from many countries. Obviously, all of the patients were treated in the clinical trial setting, and the response for Ipi/Nivo is only 10%. So there's a concern about, is this going to be cross-resistance? And there's a question about the same exact thing from the audience. And I will say that it's really early data. It was just, again, it's not yet, Nivo-Rela is not yet in clinical practice. It's a super selected population. It was already on clinical trial and went to Ipi/Nivo. So it's interesting, it's food for thought, but I think exactly the way that DreamSeq helped us answer a question with a randomized study that clearly designed the sequence and order, kind of randomized the patients to get them, or Sequential or the EORTC trials. We will need trials that will help us decide how to sequence Nivo-Rela, and I wouldn't take this, 10% response as gospel. It's very early. I think it's interesting. It was good that we put it out there so people know what you might be dealing with, but it's not going to affect my clinical practice in any way yet. All right, let's see. When do you use PD-1 alone in advanced melanoma? This will be our last question because we're already past 8 o'clock, but I think it's relevant to address that question.
I alluded to it earlier. possibly, patients with normal LDH, very low tumor burden, maybe the M1A, or those with isolated lung, one or two lung metastases, I may still use PD-1 monotherapy.
Or patients who are more fragile.
Correct, yeah. Concerned about adverse events.
Very, very old, or like a little bit on the autoimmune side.
Yeah, so those are all very fair points. And again, this will be a debate we're all going to be talking about. It's good to have options to kind of de-escalate if you need it to single agent. Again, we'll show on Sunday specifically results in the patients over the age of 75 where there's still benefit. Patients that M1A and M1B disease where the response rate is more than 55%. So, personally, maybe I may be biased, but I do find it really hard to consider single agent. I will give you the autoimmune disorders question. We still don't know. We're running a clinical trial nationally where we're doing nivolumab single agent in patients with varying degrees of autoimmune disorders. So obviously, not all autoimmune disorders are the same. Somebody with mild psoriasis is different than somebody who has multiple sclerosis, right? So there's varying degrees. But we're running it with single agent PD-1, and we want to actually now add nivo-rela so that we can examine that specific combination in those patients. The last thing I'll say about nivo-rela is we don't know its activity in the brain at all, and I think that's a really, really critical component. So if you have a patient with brain metastases, ipi-nivo is really the most appropriate tool for those. Any last words from
Yes,
from
and
my colleagues?
no burning question in the audience? No, yes.
One, go ahead.
Yes.
Go ahead.
Which normally use single agent. Is there any subtype of melanoma, like desmoplastic or?
Go ahead.
Right, and yes, it's a good point because of the good responses. We had this paper published by Tony Ribas and his team about the very good response of desmoplastic melanoma with anti-PD-1 monotherapy. It's a good point. I think this would be part of the criteria to decide. It would be maybe in favor of using PD-1. I think it's a good point.
Yeah, Kerry Kendra is presenting the results from a SWOG study on Sunday as well with desmoplastic melanoma. It was really impressive response rate with single agent. But the flip side to that is if you have mucosal or acral melanoma, single agent doesn't do as well. You remember those are melanomas that don't have a high tumor mutational burden, so we generally favor combinations for those patients.
Yes, but combination does not do perfectly well either.
It still doesn't do great, but it does better than single agent. Yeah. That's kind of...
Yes. Good point. Yes?
Thank you. A quick question. If you decide to start to target therapy combo due to the pace of disease, when do you switch to immune combo? You wait progression or you change before progression?
Excellent question. Dr. Tarhini, what do you think?
I think based on the DreamSeq data, we will always have to add immunotherapy, either as a triplet or switch to ipi-nivo, depending on the extent of the response. Somebody has a great response with, let's say, BRAF-MEK inhibition, I may just add, let's say, atezolizumab, for example, or anti-PD-1. But I think I would be hesitant to treat with BRAF-MEK alone, especially in those who have such a high tumor burden, such a bad performance status to start, and they're high risk to come back. And one observation in the DreamSeq study, 24 patients died on the study early. And when we looked into those patients, the common factor was that none of them received BRAF-MEK inhibition in salvage after ipi-nivo. Which it kind of calls for the fact that there are these patients that we need to salvage them quickly with BRAF-MEK inhibition, but I think we need to consider adding immunotherapy soon after.
This is exactly the question that we try to address with the ERTC trial with BRAF-MEK for a short period, followed by ipi-nivo versus ipi-nivo.
But the current evidence is lacking. I mean, that's the truth, right? So, the idea of doing short sequence and going to it is we're waiting for those. Sequential had that for 2 months, and is that the best? I don't know. I mean, it'll be interesting to see. But waiting until progression is the only kind of, data that we have now, and it's not good. It's not a good outcome. So, Yeah, and the other thing I'll just say, mention very briefly, is we're seeing, I'm not sure if that's your experience as well, don't want to be kind of promoting one combination over the other, but I feel like with BRAF-MEK that we currently have, there's more stability over a longer period of time. I used to get really nervous at the 8-month mark for my patients, at the 10-month mark, and now the 12-month is coming, and it's, the 15 months are coming, and it's not as bad. So perhaps our agents are a little better as well. The point is, when you get closer to these, 1 year to 15 months period, I start kind of checking on those patients a little more frequently so that you don't do the every 3 months and then you might miss the progression and miss the opportunity to intervene for those patients. But that's all clinical practice, not evidence driven.
But unfortunately, the reality, most frequently, if you stop your targeted therapy to try to initiate an immunotherapy, sometimes you have to really re-challenge with BRAF-MEK inhibition rapidly because it's very difficult to stop.
Yeah, and I think one observation was important observation in DREAMseq is that the likelihood of response with BRAF-MEK is similar whether you give it first line or second line after Ipi/Nivo. So the response rate is similar. While with Ipi/Nivo, the response rate is less if you give it after BRAF-MEK.
Yes,
so these are excellent salvage agents.
I think it's very important because that's what I wanted to say and I forgot. We don't say that BRAF-MEK inhibitors are not good treatment. It's excellent treatment for patients who are rapidly threatened by their metastasis or second line, because immunotherapy does not work all the time. We know, unfortunately. So it's so good to have such an effective second line treatment with such a good response rate, almost the same as in first line. So it's very important just to keep that in mind and not to say that targeted therapy are not good treatments.
Well, thank you all very much. Thank you,
Caroline.
Yeah,
we don't stop.
This was great.
This activity is certified by PVI, Peer Review Institute for Medical Education. Remember to download the slides and practice aids.